So I'm going to talk about some other modalities to treat ocular melanoma once it has spread to the liver. I know that Dr. Harbour touched upon a bunch of clinical trials before, and there's one other one that we'll discuss right now. So mainly we're going to talk about percutaneous hepatic perfusion. And just a little background, liver metastases, primary liver tumors are a significant cause of morbidity and mortality in patients and in the United States. If we can resect them surgically, if we can take them out, that's considered the standard of care. However, only a small percentage of patients are really amenable to surgical resection. With the potential for occult microscopic disease, when you have small little dots of disease in the liver and we can't see it on scans, and when bulky metastases are also present, surgical and local treatments are not optimal. So liver metastases are primarily nourished by the hepatic artery, and regional chemotherapy, where we perfuse the liver, the entire liver, with high-dose chemotherapy, takes advantage of that anatomy to deliver that chemotherapy into the hepatic artery directly to the liver tumors. And the Melphalan percutaneous hepatic perfusion allows for high concentrations of chemotherapy to be delivered directly to these tumors. And then we lower the systemic side effects and the systemic exposure of this chemotherapy by filtering it outside the body. So here you see a couple pictures of what liver tumors actually look like in the patient. And you can see here, there's no way we're going to be resecting these tumors. You can't ablate all these tumors. So if we could, surgical resection is the standard of care. Arterial embolization, hepatic artery infusion, radiofrequency ablation, cryotherapy, Y90, radiation, systemic therapy, clinical trials, open hepatic perfusion, and then chemosaturation therapy or percutaneous hepatic perfusion are really all the options. I'm going to focus, no pun intended, on PHP and the focus trial that we have open right now, which is the new phase 3 trial treating patients with ocular melanoma metastatic to the liver. So again, the PHP or percutaneous hepatic perfusion has three primary principles. One, we're going to isolate the liver. We're going to insert a catheter inside your femoral artery, the vein in your leg. That catheter is going to be snaked up in interventional radiology, and then we're going to place balloons. This catheter has balloons. The balloons are situated right above and right below the hepatic veins, the veins that drain the liver. The balloons are blown up, and it effectively isolates the liver from the rest of the body. Afterwards, we have an arterial catheter that's put in the femoral artery. That catheter is going to saturate the entire liver with high-dose chemotherapy, high-dose Melphalan. And the balloons that are above and below prevent that chemotherapy from getting all over the body. Then the catheter that's placed in here has fenestrations in it, has small holes in it. We actively pump out all the blood that's collected in the liver and all the chemotherapy. We filtrate it outside the patient's body, and then we return the clean blood back into the internal jugular vein. So the patient then is basically on bypass through the procedure, and all the chemofiltrated blood is returned to the patient through the internal jugular vein. But it takes a huge team to do this. Usually a surgical and a medical oncologist are part of the team, and usually captains of the team. We must commit to managing the patients before, during, and after the procedure. We definitely need an interventional radiologist, and that's the one who snakes these catheters up into the patient's liver. An anesthesiologist, because there are some key times during the procedure where an anesthesiologist is critical. We need a perfusionist to run the pump, the pharmacist to mix the drug, nurses, interventional radiology staff, and then myself, or in other centers, critical care specialists to take care of the patient immediately after the procedure. So the FOCUS trial design, which is ongoing now, is going to randomize about 240 participants. At least half will come from the United States and the other half will come from Europe. We're expecting about 35 hospitals to be enrolling patients. And what we're doing is we're comparing the Delcath percutaneous hepatic perfusion to standard treatments that are out there. The treatment is randomly assigned, so you have a 50-50 chance of going on the PHP arm or the best alternative care arm. We're measuring overall survival in the trial. And we're also looking at how long it takes for the cancer to progress, the proportion of people who get better, we're asking the patients how they feel during the trial, and a bunch of other specific goals for the trial. The other options that are standard for the trial, the best alternative care options, are chemotherapy, immunotherapy, and chemotherapy or delivered by beads or chemoembolization directly into the tumor. And then we periodically get CAT scans and MRIs done about every 3 months from the study enrollment. So if you're assigned to the Delcath arm, you're going to get treatment about every 6 to 8 weeks for up to 6 treatments. Each Delcath treatment involves maybe a 2 to 3 day stay in the hospital. I usually admit the patients the night before. We treat them the following morning. They stay in the ICU the day of treatment, and then most often the patients are discharged the very next day, day 1. If you're assigned to the standard treatments, then whole body chemotherapy or immunotherapy is given per the schedule. And I have the patients come back frequently for blood work and obviously for scans. Qualifications for the study: you have to weigh at least 80 pounds, no more than half the liver, no more than 50% can be involved. You're allowed to have cancer that has spread to the skin, lung, or bone as long as it's limited, and we like to be able to treat these small other tumors. In between treatments, we want to have a plan to treat these because we're going to perfuse your liver, and if we have other disease throughout the body and we let that go, that's not really going to help the patient. So I usually like to have a plan to treat these either with radiation or resection of small subcutaneous metastases. You have to be in good health status, have a healthy liver, and have healthy blood work. You can't have cirrhosis, active heart or lung problems, bleeding disorders, cancer that spread to the brain, diabetes that's not controlled, and be pregnant. So there's a bunch of participating hospitals. Moffitt Cancer Center, where I work, is the lead site for this international trial. And we have, again, we're going to have about 30 to 35 hospitals worldwide, and these are some of the hospitals that are currently open or on the cusp of opening the trial at their site right now. So we recently completed a phase 3 trial about 4 or 5 years ago, and I'm going to just go over the results of that so you can see what we have done now that you know what we are doing. We published the results of this trial in Annals of Surgical Oncology last year. And here you can see the results of the trial. These are called Kaplan-Meier curves. I think you've all seen these before. But we're comparing here hepatic progression-free survival. So how are the liver tumors progressing in the liver, the ocular melanoma in the liver? And as you can see here, the PHP arm is in yellow, is significantly better than the best alternative care arm. Overall progression-free survival was again in favor of PHP versus best alternative care. Overall survival was the same. So someone would ask, why was overall survival the same in this trial? Well, it was a crossover trial. So patients who progressed on best alternative care were allowed to then cross over to the PHP arm. And if PHP works very well, which I think it does, that might salvage some patients and make these lines come together. Here you can see when we look at the best alternative care patients, those that were able to cross over and get percutaneous hepatic perfusion after 20% progression of their disease from baseline in their liver, they had a favorable outcome when compared to the patients who had best alternative care who were not crossed over. So we've been doing this at Moffitt. I've been doing this for, I guess, almost a decade now. And these are some old data, but I thought maybe I'd show you the experience at Moffitt. So according to this slide, we had 18 patients that received nearly 60 treatments. One patient we did have to abort because of anatomical constraints. I couldn't seat that top balloon above the hepatic veins, and if we can't seat the balloon, then you're going to get a huge dose of Melphalan. The median age was about 60 years old. Patients had a median of 3 PHPs, and nowadays we're really pushing the limits up to 4, 5, and 6 in most patients. Half the patients had previous therapy before PHP, and as you can see, most of these patients on this slide had ocular melanoma, and a few had other diagnoses. There were 17 patients that were evaluable for response, which means at least 6 weeks after the liver perfusion. The median follow-up was just over a year. One patient had a complete response. 41% of patients had a partial response. Another almost 50% of patients had stable disease, for a total control rate of their disease of just over 94%. And the median hepatic progression-free survival, the time it took to have the liver disease progress, was almost a year. Here you can see a list of those patients. Again, this is somewhat old and needs to be updated, but these patients are getting 4, 5, and 6 liver perfusions and having liver progression-free survivals measured in years. Here's a waterfall plot. It just shows the tumor response, the best tumor response from baseline. So if we measure everybody at baseline and then your tumor grows, the bars will go up. And if the tumors respond, the bars are going to go down. This star represents somebody who had space-occupying lesions in the liver. We did a PET scan. All the lesions were dead. We didn't light up on PET. We went ahead and biopsied the lesions, and the pathologist said that it was all dead and necrotic tumor. So she basically had a pathologic complete response, even though we can still see some tumors on scan. And some would ask, why would we do this instead of other regional type therapies like Y90, where we put radioactive beads in the liver, or chemoembolization? Well, we took a couple of our patients that we can find with similar diagnoses, and we compared PHP to chemoembolization in Y90. And again, you can see here, the hepatic progression-free survival in this small retrospective type study was significantly in favor of PHP versus the two others. And again, another type of plot here called a swimmer's plot, where the time to progression is listed on this axis, and any lines with arrows means that these patients continue to have progression-free survival. Again, we looked at overall progression-free survival, and that's significantly in favor of PHP, and that same type of curve, the swimmer's plots for progression-free survival. And just a couple of scan examples of patients with liver perfusion. So you can see here, this patient had 2 tumors right before we did the first PHP on this patient, and then 6 or 8 weeks later, these tumors are already a quarter of the size of it was that they were at the baseline, and this patient wound up getting 4 PHPs. Again, that PET scan that I talked about before, here's a PET scan showing the activity in the liver, that space-occupying lesion on the CT portion of the PET scan. 3 months later, PET scan activity is mostly gone. That space-occupying lesion is still there, maybe a little bit smaller. So we follow the patients with CTs and MRIs of the liver, as well as PET scans, to just gauge that biologic activity if the tumor is going away. There is some toxicity associated with PHP. Mostly it's hematological. Even though we want to filter out all the chemotherapy, there's a small amount of chemotherapy that does get into the blood. This is vastly treated as an outpatient. Usually before, the day after or 2 days after the procedure, you get a shot of Neulasta that boosts your white blood cells, and then there's really no other problems hematologically with these patients. One patient in my series did have a pulmonary embolus, which is asymptomatic and found on follow-up scans, and we treated it as an outpatient. And some patients have some cardiac events. One patient had VTAC but actually did fine, and one patient had probably a reaction to protamine, which reverses the side effects of, reverses the anticoagulation that we have to do when we put all these catheters and balloons in the IVC. We want the blood to be thin so there's no clotting. Sometimes we reverse that protamine action at the end of the case, and they're heparin with protamine, and you can have a reaction to protamine. But as you can see here, when we follow patients with their white blood cells counts, because the hematologic toxicity, you can see these really don't drop to dangerously low levels. The red blood cells or hematocrit really doesn't drop to dangerously low levels, and the platelets stay, for the most part, above 150,000, which is completely normal. So again, chemosaturation, PHP, it's these 3 principles: isolating the liver, saturating the liver with high-dose chemotherapy, extracorporeal outside the body filtration, and veno-veno bypass, so we can return that blood back to the patient. For more information, you guys can go to the clinicaltrials.gov. You can feel free to call me or email me at any time and ask me any questions. And I heard that these slides are going to be available, so my email is open for use for any of you. And I'd be happy to answer any questions that you might have. Yes, sir.
So can you tell me, with your clinical trial, do you expect to get any pushback from patients who are definitely interested in PHP but know that going in your clinical trial, they only have a 50-50 shot of getting it?
Yeah, there probably would be some pushback for patients, but I mean, in order to design a proper trial, we have to know if PHP is better than best alternative care. Now, while best alternative care might not be great, it's the only thing that we have to compare to. We can't compare it to other experimental treatments. So then the other option is to go on another trial which might have the same type of comparison if it's a phase 3 randomized trial, or take best alternative care without entering the trial. But I think 50% chance is the best we can do right now, unfortunately. And hopefully this will be a successful trial and then it'll be open to everybody. Any other questions? Yes?
With the approval process, if it ends up being highly successful, is there any idea of how long it would take for it to not be in phase 3 and no longer 50-50?
So at the end of the trial, obviously there's going to be a lag time where we gather all the data, analyze the data, then you have to go to the FDA, you have to show the data. There's numerous different hearings and meetings at the FDA, and then hopefully afterwards it's going to be a short process to get it approved, especially if it's highly effective. Sometimes the FDA can help speed up that process somewhat. But there is some lag time between enrolling, gathering the data, follow-up, because it's a survival-based trial, and then we're going to have an interim analysis as well, so maybe at that interim analysis we'll see something. Yes, sir.
Johnson, do you all take a baseline liver biopsy and do any kind of molecular biomarkers to try to identify markers for predicting who's going to respond well and that sort of thing?
So we do take a baseline biopsy because we have to prove that there's disease in the liver prior to enrolling on the trial. But no, as part of the trial, we are not doing any molecular diagnostics and looking at any biomarkers in the tumors. Any other questions? All right, well, thank you very much for your attention.